you take up. Huh? Yeah. So you can start, Professor Chatterjee.
Sir, Sagir has to allow me to share my screen.
Sagir, you allow screen sharing. Sagir has some microphone issue. So Sagir, allow Madam screen sharing.
Yes, he has allowed. Clinical Excel. Yeah. Okay, can you see my screen?
Yeah, your sound is little less, Dr. Chatterjee.
Okay, I'll hike it. Can you hear me, sir, now?
Better, but still low.
Okay, I'll just see what I can do.
The screen is visible.
Screen is visible. Sir, can you hear me now?
Better.
Okay, sir, I'll then start. So who's going to take the first image?
Saptarshi, can you hear me? Saptarshi.
Yes, sir.
You have to unmute.
Yes, sir. Yes, sir.
Yeah. You take up the first scenario.
Yes, sir.
Okay.
Okay. Good morning, Shaptoshi.
Good morning, ma'am.
Good morning. So this is your first image. Take a good look at the image. Okay. So this patient has underwent an open CBD exploration 3 days back, and the patient was not doing well, was having tachycardia. So you did this X-ray. Okay. So you did this X-ray, and this is what the X-ray shows. Can you describe the X-ray?
This is the X-ray of chest in AP view with showing the both halves of diaphragm, and in this showing a free air under the right side of diaphragm.
You think it is free air under there? Anything else? Just be a little more cautious. Read the X-ray a little better. Anything else?
Can you find a line?
The right diaphragm is pushed upwards.
Right diaphragm is pushed up. Look at the what you said, air under the diaphragm. Look at it a little more cautiously. Do you see a very distinct margin in that air?
Air fluid levels.
So it looks like an air fluid level. So now would you like to revise your description, please?
This is a X-ray of a chest in AP view showing both
You say AP
halves
view
of
is not the right answer.
Why are you saying AP
I'll
view?
ask you, what is AP and PA?
Why are you saying AP?
PA view, because the posterior ribs are more better
So
visualized.
in an AP view, which structure is most prominently visible?
Yeah.
Heart is.
No.
Cardiac.
In
AP view, the
vertebra.
bony shadows are better seen.
See, the rays will go from anterior to posterior, and the plates will be behind you. So the vertebral body is closest to the plate. So the vertebral shadow is most prominent in AP. In PA, the plate is in front of your chest, and the ray is coming from posterior to anterior. So the heart shadow is prominent in a PA view, like in this image. Okay, so this is a PA view. So this is a chest X-ray and X-ray of upper part of abdomen in PA view. And now you said you can see both hemidiaphragms. Right side hemidiaphragm is elevated. What do you see below the hemidiaphragm?
Air fluid level is seen.
So you can see an air fluid level. Now, what is your diagnosis given the clinical scenario that I described to you?
there may be a collection
You think there could be a
of leak.
collection? So if there is a collection, why will you have air?
If there is a bowel leak, then
Do you get if in case of a bowel leak, why will you get an air fluid level? When do you get an air fluid level in the subdiaphragmatic space?
we can see
Yes, please.
as there is CBD external close laparotomy, air can be there. And
Sorry.
ma'am,
Post-operative.
as this is a post-operative patient,
Yes,
ma'am,
post-operative. Yes.
so air can be normally present.
For a CBD exploration, why will you have air? Think about it. Patient is 4 or 5 days post CBD exploration. He is not doing well. He is running fever, and his chest was also bad. So you did an X-ray in addition to other examinations, investigations. I'm not going into that. So what will be your suspicion?
There can be a bile leak from the
Anyway, I think you have to come out of your leak. Just think of it. If there is an air fluid level in the subdiaphragmatic space, it is a very clear-cut indication of a subdiaphragmatic abscess. Okay? Are you with me? Right?
Yes, ma'am. Yes, ma'am.
So
Yes,
in a patient, so that is what I said. I wanted to, next thing is that if I tell you the diagnosis that it is a subdiaphragmatic abscess, then what are the 2 points in favor of your diagnosis from this image? What are the 2 points?
There is a air fluid level in the right half of the diaphragm, and the right half of the diaphragm is pushed upwards.
Exactly. So the right diaphragm, hemidiaphragm is pushed upwards. There is an air fluid level. So how will you differentiate this from an X-ray of a hollow viscous perforation? There also you get air under the diaphragm, free air under the diaphragm. How will you differentiate this?
There will be seen the liver margin, ma'am. There will smooth.
Okay, what else? What else? How is the shape of the air different in a case of a hollow viscous perforation as compared to a subdiaphragmatic abscess? So in a hollow viscous perforation, you have an elliptical gas shadow. Here you have a air fluid level. Do you understand the difference?
Yes, ma'am.
Elliptical meaning that both lines are curved. The superior part will be obviously curved because of the outline of the diaphragm, and the inferior line is also curved. Okay? But here you will see a straight line at the bottom, which is because of the fluid interface of the fluid and the gas. Okay?
Yes, ma'am.
Yeah. So if this is a suspected case of a subdiaphragmatic abscess, what will be the clinical presentation? I had said it is a post-op patient, but what is the clinical, how will this patient present clinically?
On symptoms, the patient may be complaining of fever, high-grade fever, with
Okay.
with chills and rigor, and then patient have anorexia. And on clinical examination, I can found the abdomen to be tender, and rigidity may be seen, and pulse tachycardia will be seen.
Why will there be rigidity and guarding or whatever you said? Why will there be that?
Because ma'am, collection is present in the abdomen, so it will cause a peritonitis.
Will it be a generalized guarding and rigidity in a subdiaphragmatic case?
Localized only.
Exactly. So first and foremost, your patient will look sick. There is going to be tachycardia. Okay. Patients may be having fever, as you said, high fever. The chest is going to be bad. Think holistically about a patient. On abdominal finding, usually there is tenderness and there may be localized guarding in the right upper quadrant. But yes, if it is a very advanced case where the abscess is communicated with the whole of the abdomen, you may have features of peritonitis. But the initial finding is there is tenderness in the right upper quadrant with localized guarding. Okay, what will be the initial step of management of this patient? Initially, first we will resuscitate the patient. Okay,
uh,
patient is already admitted
NP
under you. He is a post-op patient. So what will you do?
uh, First, I will escalate the antibiotics, do NPM fluids, and then we'll go for any imaging, USG, to look for the amount of collection, and if it is drainable, we can drain the
Okay.
collection.
So the first thing is you have patient is probably already on IV fluids. You have to send a count of the patient. You must know whether there is an increase in count since your previous post-op count, right? Number two,
Yes,
you correctly said that you are going to escalate the antibiotics.
sir.
Okay. So what antibiotic are you going to use? What will be
Uh,
a good option for this case?
we can escalate piperacillin tazobactam or meropenem.
You don't jump
What are the likely
directly.
bugs? What are
What
the
are
likely
Uh,
bacteria? If it's a biliary surgery,
gram negative bacteria can most commonly, and anaerobes.
so
Gram
what is
negative bacteria, sir.
okay, so what is if you say it is a gram negative, we have done a biliary surgery. What is the best antibiotic post-operatively for where in a case where there was an obstructive biliaropathy? This patient has a biliary CBD exploration, meaning there must have been an obstructive jaundice. So what is the best antibiotic if there in a case of obstructive biliopathy?
Uh, amicus,
No.
amicacin.
You have to have an antibiotic which is secreted in bile. So this was a stagnated bile system. So usually it is cefoperazone sulbactam. That is the best antibiotic if you are doing a surgery in an obstructive biliopathy. Now, as you said, you have to escalate this. And yes, piperacillin tazobactam is a good option. Piperacillin, but you will not jump directly to meropenem because you have to, go in a stepladder fashion to see how well the patient is responding. So you said you are going to resuscitate, you are going to give IV fluid, and then you are going to escalate the antibiotics,
Simple.
and you want to do further investigation. What further investigation would you like to do?
We can do a ultrasonography of abdomen
Okay,
to
so
look for the amoxicillin.
ultrasonography, they confirm your X-ray suspicion that there is a collection in the subdiaphragmatic area and some amount of interloop fluid. This is a classical description. So if that is the case, what will be your next plan?
Uh, Ma'am, if it is amount is less, we can just observe 1-2 days with escalating the antibiotic whether the patient is improving or not. And if the patient is not improved
Wait,
after 1 or 2 days, then
one step at a time. So if the patient is improving, then you continue with your antibiotics, right?
yes, yes, ma'am.
Okay. Now, as you said that after the fluid was less, but the patient is not improving, his fever is spiking, his counts are further rising. Okay.
Yes, ma'am.
What will you do?
Then we can do a image guided percutaneous drainage.
So you want to do
Uh,
an image guided percutaneous drainage. What sort of percutaneous drainage do you plan to do?
Pictal
Pigtail.
drainage.
So you said that the fluid was very less. If the fluid is very less, then you can do a one-time aspiration. And if the fluid is more, you can leave a pigtail so that the fluid is drained, the content is drained. Okay?
Yes, ma'am.
Right. Now you see that even with a pigtail, patient is not improving. Patient's abdominal condition is deteriorating.
Uh,
Okay?
Ma'am,
What
we have
will be your suspicion?
uh, ma'am, we have to see whether the content of the pictal drainage, whether
Hmm.
it is only purulent or there is any bile. And
So let's say, okay, since you asked for it, it is a bile mixed, pus mixed with bile. Okay, it's a pus mixed with bile. But his counts are also increasing in spite of a pictal drainage, and his abdominal clinical findings are deteriorating. So what will be your next thought? Options of a definitive management of this patient.
uh, we can do an MRCP to look for any leak.
You want to do an
emergency.
MRCP for the leak. Okay, that is a fine, but my point is, how will you manage this? The MRCP will only tell you, yes, there is a collection and we cannot see much
Yes,
because it is
MRCP cannot
totally,
show you the leak. It's not
yes.
a dynamic imaging.
Yeah, so it will be just show a white area. You cannot understand. If there is a collection, an MRCP does not become very effective.
Then, ma'am, we have to take the patient to OT for exploratory laparotomy and
Okay, so you
do
want
a
to
thorough
do,
wash.
okay. Is there any less invasive method instead of an exploratory laparotomy? Can you do something else in 2020?
Diagnostic laparoscopy.
Exactly. So you can do a diagnostic laparoscopy and lavage, but if you see that if necessary, if the facility is not available or the patient is very sick, yes, you are justified in doing a laparotomy and a thorough lavage. Okay. Now, are you clear about this? Because the first thing why I
Yes.
put this X-ray is you have to identify an air fluid level from an image of a hollow viscous perforation. Hollow
Yes, ma'am.
viscous perforation is the commonest X-ray given in an exam, but you will be exactly what happened with you. You know, you may confuse it with a this X-ray with a hollow viscous perforation. So you have to identify one from the other. Are you clear on this?
Yes, ma'am.
Okay, fine. We'll move on to the next image. Who's going to take the next image?
Shagota.
Shagota.
Shagota, you can unmute.
Okay.
Shagota, are you there?
Yes.
Yes, ma'am. I'm there.
Right. Shagota, this is your image.
Yes, ma'am.
Can you describe this, please?
Ma'am, this is a T-tube cholangiogram image with T-tube in situ.
Yes, and what else do you see?
Uh,
You've been asked to describe.
there is a radio lucent
Man,
shadow
what are you
at the
looking at?
What are
It
you
is
seeing?
in situ.
common
What
bile
is
duct is
seen?
dilated.
Hmm.
Extrahepatic biliary radicals are not that much dilated, mildly dilated, and at the distal end of the common bile duct,
Extrahepatic or intrahepatic? What are you
sorry,
saying?
ma'am, intrahepatic.
Intrahepatic, yes.
And the distal part of the CBD, there is a rounded radiolucent shadow, appears to be a stone impacted at distal CBD, ma'am.
Okay. So the moment you have a T-tube cholangiogram, basically we are looking at 5 things. You have to say 5 things. Number 1, it's an image of T-tube cholangiogram with T-tube in situ. Okay.
Yes,
Number
ma'am.
2, whether the CBD is dilated or not. Number
Yes, ma'am,
3,
dilated, and
yes,
the dye not that much reaching the duodenum. Dye is
exactly.
not. Yes, yes.
Exactly. So the third point will be whether the intrahepatic biliary radicals are dilated or not. Fourth, whether the dye is moving into the duodenum or not. And last, what you said, whether there is any filling defect or not. So these are the 5 points that you have to say when you are describing a T-tube cholangiogram.
Okay, ma'am.
Right? Okay.
Yes.
So you said that there is, now what is your diagnosis? This is your description. What is your diagnosis?
Impacted stone in distal CBD with obstructive causing CBD obstruction.
You have to add. This is a T-tube. So this is a missed or retained CBD stone.
Yes.
Okay,
So you were
ma'am.
just saying impacted. If it was a totally impacted stone, would you have got any dye in the duodenum?
No, there is trace
Can-
amounts of dye in the
Yes. Can you
duodenum.
see that there is dye here? Can you
Yes,
see
ma'am.
it? Yes.
Yes,
So
ma'am.
you cannot call it an impacted stone, right?
Okay, ma'am.
So then what will you say? As sir
This
said,
is
that this is a missed stone.
missed soon after CBD exploration laparoscopic.
What? Laporo?
Laparoscopic or open after
Why are you going
laparoscopic.
into that? You will be dragged into that, right?
Okay, ma'am.
So just
Maybe
say that it is post
after
CBD.
hmm.
If both of us talk together, it is ineffective. Okay, so now tell me, just revise your diagnosis and tell me again.
And this is a T-tube cholangiogram with T-tube in situ showing the dilated common bile duct with mildly dilated intrahepatic biliary radicals and very trace amounts of dye going to the duodenum as well. In the distal part of the common bile duct, we can appreciate a rounded radiolucent shadow which seems to be a common bile duct stone at the distal end of CBD,
Again, you
causing
missed what sir said. Not saying just
with a
it's a retained stone or a missed stone.
retained or okay, retained
Okay.
stone after an intervention
You have to be very
or
precise, okay?
surgery or
Whatever you say, please be very precise. Okay, now tell me, this patient, you are the resident, how will the ward charts read? You are monitoring the patient every day. It's a post-operative patient. How do you think the ward charts are going to read now? Meaning, how will your daily notes, your findings, your everything, how is it going to differ in this patient from a standard patient with a clean T-tube cholangiogram?
And since there is distal obstruction at the CBD, there can be signs of cholangitis present in this patient.
Why will he have cholangitis?
T-tube is draining outside.
T-tube is draining,
Okay.
exactly. Why will he have cholangitis?
In the LFT, there will be raised.
No. Even LFT will not show rise because
Okay.
T-tube is draining. If you take the output in the T-tube, what is the chronology on first post-op day, second, third, fourth, fifth, sixth? What happens?
What happens? Does it increase? Does it decrease? What happens to the output?
The bile drains through the T-tube if there is any distal obstruction present. So the bile will be draining through the T-tube, and if there is a stone in the distal CBD, it will not pass into the duodenum. So and it will be coming through the T-tube if there is
We
no other.
understand that, Shagota. My point is, from day 1 to day 2 subsequently, what happens to the amount of bile coming out of the T-tube? Does it increase? Does it
It will
decrease?
decrease. It will gradually.
Now, what will
Yes.
happen to this patient?
It usually generally decreases, but in this patient it will remain same.
Yes.
Exactly. So that is the simple one way. It's an OSCE, you have to be precise. So because there is an obstruction, distal flow of bile will be hampered. So you will see that there is no decrease in the T-tube output on the subsequent days. Okay.
Yes, ma'am.
What
Yes.
may be the what may be the complaints of the patient in such a case?
Pain in right upper quadrant, and
So the patient may complain of a pain in the deep pain in the abdomen. Will he have jaundice?
since the T-tube is draining the bile,
No.
jaundice will not.
Simple answer is no, he will not
No,
have
no,
jaundice.
no.
Okay. Will he have an escalation in count?
No, ma'am. It is draining bile. Is draining.
Exactly. So there will be no jaundice, no
No,
cholangitis, but the
no.
patient may complain some sort of a lower abdominal pain.
Lower
Further,
abdomen.
how will you further manage this patient? This is your T-tube. How will you further manage this patient?
Ma'am, uh, we can go for less invasive ERCP.
So don't say
And
less invasive. ERCP is not less invasive. So the
less
straightforward answer would be, sir, I would like to go for an ERCP and take out the stone. And at the same time, what will you do with if you're doing an ERCP?
Ma'am,
Yes,
sphincterotomy should be done, ma'am.
obviously, sphincterotomy. Now, do you think this patient did not undergo ERCP prior to surgery? Nowadays, we hardly ever go for upfront CBD exploration, isn't it?
Yes, ma'am. Maybe the stone size and duct diameter, if it was more than 1 centimeter, generally in our setup, we go for laparoscopic or open CBD exploration, ma'am. And if the duct diameter, common bile duct diameter is less and the stone.
Any gadget in the hand of endoscopist who can remove larger stone?
Ma'am, sir, lithotripsy, it can
Exactly.
break
So
the stone
yeah.
and remove it.
Okay. If
Yes.
it was a smaller one, This is a significant size stone in lower
Yeah,
CBD. If it was a very small filling defect, are there any forms of medical management that can be done to remove these stones?
Hyoscine bromide injection can be
Okay,
given.
so that is basically relaxation of the sphincter of OD, right? Anything else that you can do, something like where you can flush off the stone? That is only possible if there are very small stones, not so with such a large one.
Heparinate normal saline solution through the T tube.
Only normal saline or anything else?
Heparinase, ma'am. Heparinase.
Heparinase, correct. So,
Heparinate.
yes. So with small stones, yes, you can do a heparinase, but ERCP is the standard of care. And if it is a large impacted stone and ERCP is having difficulty, then you can combine it with a lithotripsy and take out the stones. In that case, you might have to put a stent in the CBD if you're doing a lithotripsy, because again, small fragments might stay back. And before putting the stent, you have to take out the T-tube, because inside the CBD, a stent and a T-tube cannot coexist.
Yeah. Usually the stent, they remove the T-tube.
Yes, that's what I say. You remove the
Yes, ma'am.
T-tube and you keep the stent.
Stent
Okay?
only. Yes, ma'am.
Fine. Who's going to take the next one? We'll have to move a little faster.
Anand Bharate.
Okay,
Yes,
Anand.
sir.
Yeah. And Shagota, you will have to speak more precisely, because you will not get so much time with an OSCE session. Okay?
Okay, ma'am. Okay, ma'am.
Right, right. Okay, Anand, this is your image. Now tell me, describe. Anand, are you there? Yes, please.
Anand is unmuted. Yes.
Yes,
Yes.
Anand, please describe.
Yes, ma'am.
You have given a clinical scenario also? No. Okay,
So
fine.
this patient came with pain upper abdomen. He had one episode of hematemesis. Okay, he had one episode of hematemesis. Initial USG just said that the stomach seems to be distended, nothing more. Then an CT was done, and this is the CT image. Anand?
Yes, ma'am. Actually, my network got interrupted in
No, I
between.
can hear you now. No, just describe this CT, please.
Now it is actually dilated stomach with air fluid level. I can.
No. Look at the stomach wall carefully.
Stomach wall thickness is present, sir.
Where? Which part?
Which part?
Pylorus.
The part of the stomach towards the.
Yeah, so he said pylorus, towards the region of the pylorus.
Yeah.
Okay. See, you have to be a little more descriptive. So what sort of a CT is this? Is it a contrast CT? Is it a plain CT? What sort of a CT is it?
Ma'am, contrast enhanced.
What sort of contrast do you think has been given? IV contrast, oral contrast? What contrast has been given in this image?
IV contrast, ma'am.
The only IV, because you can see this is the aorta, right? Can you see the pointer?
Yes, ma'am.
Yeah. So only IV contrast. Okay. What sort of a cut is this? You have different cuts of CT, right? So what cut is this? So this is an axial cut. Okay. So you have to say, so this is one of the slices of an axial cut of a CCT whole abdomen with IV contrast. This will be the first line of your description. Then you will come to the findings. What do you see? Look at the stomach.
Distended,
This is a
dilated stomach
distended stomach. You were
with
talking about
thickened
an
wall.
air fluid. Hold on. You are talking about an air fluid level. That is basically the fundic gas. Okay?
Fundic gas.
Okay. And you talked about, see, can you appreciate the thickening here?
Yes, ma'am.
Both in the greater as well as in the lesser curvature.
Yes, sir.
So if there is a lesser and greater curvature, we call it an annular thickening. Right? So there is an annular thickening. Is it a total cutoff?
No, ma'am.
No. You can appreciate there is a thin opening in between. So there is partial obstruction of the stomach. If there was no partial obstruction, the stomach would not be so hugely distended. Okay?
Yes.
And I had told you in the history that the patient had an episode of hematemesis. Why do you think the patient had an episode of hematemesis?
With this amount of thickening, with the circumferential thickening, what do you think?
Is the cause of the hematemesis? What do you think this thickening is due to?
Yep, do you have
Is it
peptic
likely a
ulcer?
yeast or is something else?
Peptic ulcer disease?
Peptic ulcer disease. Okay, now in peptic ulcer disease, will you have an irregular thickening like this?
No.
No. Then what is the most obvious diagnosis in this case? It is obviously a neoplasm in the stomach, probably an adenosia,
Yeah.
right? So why do you have the hematemesis? It is a bleeding from the tumor mass. Do you agree or not agree?
Yes, ma'am.
So please respond, don't keep quiet, okay?
Okay, ma'am.
So
Sorry.
so you think that this is possibly a neoplasm of the stomach, possibly a commonest one, because sir asked something. Sir asked that why do you say that it is not a gist? How would the imaging be different if it was a gist?
This thickening is going intraluminally or going extraluminally?
Interluminally, sir.
It is going intraluminally. Okay. Now, if suppose there is a confusion that you think that it is, you're not sure about the whether it is adenosia or gist. What will be your next step in investigating this patient?
Upper GI endoscopy.
You do an upper GI endoscopy and you take a biopsy, right?
Biopsy.
So, what are the findings of upper GI endoscopy in an adenosia versus a gist?
Gist is a mucosal lesion or is a extramucosal lesion?
So, as sir said, in an adenosia, you will see an irregular, it could be an ulcerative or a proliferative growth. In a gist, it is a submucosal disease. So, the mucosa is smooth. You may get an umbilication in one part of the bulge that you're appreciating, and the biopsy that you take has to be a deep biopsy, because if you take from the surface a bit of the mucosa, you will miss the disease. Okay, so this patient had an ulcerative growth on upper GI endoscopy, and you get the biopsy that it is an adenosia of the stomach. What will be your management decision? How are you going to treat this patient?
Ma'am, first I have to do
You see, outside the stomach lining, you find there are some rounded shadows. What are those?
this pointer.
Yes,
Yeah.
I put the pointer here.
Mm,
Okay, if you did not know anything about the image, if you think it is an adenosia of the stomach, what will be your management decision? How would
The
you like to
management of
manage this?
carcinoma stomach has changed now.
Yes, so how would you like to manage? And that will bring me to my next question, that what in the image will make you modify that management? Upfront tell me, if you did not know anything, what is the management of a carcinoma stomach?
Does it depend on the
uh,
TNM staging? Does the
yes, sir.
management varies based on the TNM staging of carcinoma stomach?
Yes, sir, actually.
What? Upfront
What?
surgery versus Some neoadjuvant
Something
treatment.
else, yes. So if it is a small localized T1, T2 disease, totally within the stomach with no extra infiltration into surrounding organs, no serosal disease, no lymphadenopathy, we go in for a D2 gastrectomy. But if it is an advanced disease, we will go for neoadjuvant care. We'll do a diagnostic laparoscopy, give neoadjuvant therapy, and then follow up the patient. And once he improves, we may do a definitive surgery at a later date. Now, my point is, what are the findings that you will see in a CT scan? Because this is a radiology session, which will tell you upfront that no, this patient cannot be taken up for surgery now. What are the CT findings that will tell you that this patient cannot be taken up for surgery now?
Ma'am, if
How is T staging done based on the imaging? Stomach has different layers.
sir, if it's a carcinoma in situ, that is T, and
Carcinoma in
then
situ cannot
lamina
be diagnosed
propria,
on imaging.
Carcinoma in situ is an endoscopy and tissue diagnosis, tissue
endoscopy, right?
biopsy proven. So this cannot be a carcinoma in situ by any chance.
No. T1 actually lamina propria and submucosa T1B, and
See,
then
don't go into
sir,
a descriptive mode. My question is very specific. OSCE, you have to give direct questions. What are the imaging findings which will tell you that no, whether to operate or not to operate now? So number one,
ma'am,
if you see that the disease has gone beyond the lumen of the stomach. Number two, if it is infiltrating into surrounding organs. Number three, if there is a high nodal burden. Number four, if there is evidence of peritoneal mets, ascites, or evidence of mets in the liver or any other distant site. Any of these will tell you upfront that this is not a case for surgery. However, sometimes they may not be picked up in a CT scan. That is when we do a diagnostic laparoscopy to see, suppose if there is serosal disease or small omental deposits less than 5 millimeter, which are usually not picked up on CT. If these are found, then we go for a neoadjuvant chemotherapy followed by surgery later date. Okay?
yes, ma'am.
Okay. I think I'll move to the next candidate.
Dr. Nazir Hussain can take.
Nazir, can you take this, please? Nazir, please unmute yourself.
Nazir, you can unmute. Yes.
Good morning, ma'am. Good morning, sir.
Good morning, Nazir. Yeah, so this is your image. Can you please describe the image? Again, just start your description with what I told the previous candidate.
Ma'am, this is the axial section of CT abdomen using IV contrast,
Yes.
and it is showing there is some intraluminal pathology inside ascending colon, ma'am.
Very good. So the point is, you're right, is one of the images. So always say one of the images of axial section of a CECT abdomen. Yes, with IV contrast here, you're correct. And you see that on the right of the image, the gut is enlarged in size with evidence of a filling defect within the gut, probably an ascending colon mass.
Yes, sir.
Right? This is how you're going to describe it. So you think that it could be a carcinoma cecum or a carcinoma ascending colon, something to that effect. How will this patient clinically present?
Ma'am, this patient can be presented in a mid-age or at the later age of the person's life, and can clinically be present with symptoms like having asthenia, anorexia, and anemia, or the patient may be presented in emergency with the complaints of having acute intestinal obstruction sometimes.
Okay, I'll stop you here. Right-sided colonic mass going into acute intestinal obstruction, is it very common?
No, ma'am.
No. So it is a left side where more commonly you
More
get?
common. Yes, ma'am.
Yes. So yes, anemia, asthenia, anorexia, what else? What are the other common findings?
Ma'am, hematochezia or
Yes,
altered
so
bowel habit.
absolutely. So altered bowel habits, hematochezia, and the AAA. What else? You can get a lump, such a big thing, you
Lump.
can
Yes,
get a
ma'am.
palpable lump in the right iliac fossa, right?
Yes, ma'am. Lump.
Okay, fine. Now, very precisely, what will be your management option? Give me in bulleted form. What will be your management option?
Ma'am, at first I will go for staging.
Yes. So how will you do the staging?
Ma'am,
How
CT
will
abdomen.
has been
Ma'am,
done.
at
What
first
else?
after this CT report, I should go for colonoscopy to take a biopsy to
So your
confirm.
answer will be a full-length colonoscopy with biopsy.
Yes, ma'am.
Okay, just make it bulleted points. Don't say so many things. Full-length colonoscopy with a biopsy. And your biopsy confirms an adenocia of the ascending colon. What is your next step in management option?
Then, ma'am, I will go for CT guided staging.
CT has been done. This is the CT.
Okay, ma'am. Then.
So you have a
Then,
CT,
ma'am,
you have a
after.
colonoscopy, you have a biopsy. What next? How will you manage?
Then, ma'am, I will go for if this is more than having T2, I will go for neoadjuvant chemotherapy.
Colon neoadjuvant chemotherapy?
No. T2. If there is a growth is fixed to the abdominal wall, extra
Yes, sir.
luminal
T4B.
extension,
Yes, sir.
making it inoperable, ureter involvement, kidney involvement. That means inoperable situation, you can think of going for neoadjuvant. Otherwise, if it is a mobile growth,
It is upfront
then
surgery.
upfront surgery is recommended.
Yes.
Okay. See, the point is, before I make a comment on if I am asked management options, I will always ask, sir, I would like to see the rest of the plates. Because in this one single image, you may not be able to get an answer to what sir said. Okay?
Yes. Yes, ma'am.
They may give you, they may not give you. But he said, I would like to look at the other sections to see the extent of the disease. Okay. Now let's say the same patient. This is the other image of the same patient. What do you see?
Okay, ma'am, here is I can see liver metastasis present.
A huge liver metastasis, right?
Yes, so,
Right?
yes, ma'am.
And the ureter is not visible only.
Ureter, yeah, yes, ma'am.
Right? So this is the point. If you go by one image, your decision of management might change. So here you will say management options, that I can either do an upfront surgery or I can give neoadjuvant chemoradiation and then proceed for surgery depending on the stage of the disease. And to know the stage of the disease, I would like to see the other images. Now, what sort of an image is this?
This is the coronal section after having IV contrast.
Okay, so it is a coronal section. And here you can see what sir was saying. See, you can see the mass. It's not only huge, there is extensive liver metastasis, and there seems to be a loss of interface between the liver and the colon.
Between the colon and liver, madam. Yes.
Exactly. So here your plan of management is going to totally change. You cannot take out this mass upfront. So you will probably go for NACT. So that is what he said. Does the previous management plan hold? No. Your management plan changes the moment you analyze all the cuts of the CT. Right?
Yes, ma'am.
Okay. Now the point is, now this patient, you are going to give NACT, you're planning for NACT, that the patient is having progressive abdominal pain and he is deteriorating. In the interim period, what else can you do?
Ma'am, I can go for ileostomy.
Yes. So give the correct one or two more adjectives. What sort of an ileostomy?
Madam, guarding loop ileostomy.
Guarding? Are we guarding it?
No, ma'am. We will go for loop ileostomy. Only loop ileostomy. This is
Yes.
not guarding.
Purpose of loop ileostomy?
Madam, to resolve the
So you will say, I will do a
pain.
decompressive proximal loop ileostomy. Yes, we are decompressing the gut.
Decompressing the intestine. Yes,
It is proximal, it is loop, it's an ileostomy. So 4 words only, you don't have to write big sentences. So I will do a decompressive proximal loop ileostomy. Okay?
yes, ma'am.
Fine. Thank you. Good. Okay. Who's the next candidate?
Thank you, ma'am.
Shoham, you have joined? Shoham has joined? Shoham?
Yes, sir.
Shoham
Yes,
is
sir. I
there.
have done.
Shoham is there.
Shoham can take. Yes.
Yes, Shoham, this is your image.
Ma'am, this is an image of MRCP, just a section of the entire MRCP, showing distal dilatation of the.
No, this is a complete MRC picture
Okay.
showing everything almost.
Okay.
Yes.
Okay. Showing dilatation of the distal common bile duct with
How is the dilatation? How? Describe the dilatation.
sir, this is a saccular dilatation of
Not
the.
saccular. No. Saccular is pouching outward.
Okay. Oh, sorry. Funicular.
Funicular or
Sorry.
fusiform.
Fusiform. Sorry. Fusiform.
Fusiform. So
Fusiform.
this is a reconstructed image of an MRCP showing a fusiform dilatation of the CBD.
Yes,
What
ma'am.
else? What else do you see? What else do you see?
with most probably the
What is the status of the intrahepatic biliary radicals?
ma'am, it is slightly dilated in the proximal part. With intrahepatic biliary radicals are not that dilated, ma'am.
Exactly. So intrahepatic biliary radicals are not dilated.
Not
That is
dilated.
an important finding, isn't it?
Yes, ma'am. Yes, ma'am.
I give you 2 scenarios. In one, both of them, the CBD is dilated. In one, the intrahepatic biliary radical is not dilated. In the
Yes,
second scenario, the intrahepatic biliary radical is dilated.
Yes, ma'am.
What will be the difference in diagnosis?
Ma'am, in the image where the intrahepatic biliary radical is dilated, it is most probably due to some obstructive pathology. Over here, it doesn't seem to have obstructive pathology in the distal part.
So the answer is very clear. If there is intrahepatic biliary radical dilatation, that means there is a distal obstruction.
Yes, ma'am.
Whether it be stone, whether it be neoplasm, that's a secondary question.
Yes.
If there is dilatation but no intrahepatic dilatation, then it is a, what is the diagnosis then? CBD dilatation, no intrahepatic dilatation.
Ma'am, this is most probably a case of choledochal cyst.
Absolutely. So that is how you differentiate between a choledochal cyst as well as
Which type?
Okay, now next year. What type of choledochal cyst is this? What is the classification?
This is most probably a type 2 choledochal cyst.
Type 2.
Okay, what is type 2?
Sir,
Type 2 is what you said is saccular. It's not saccular.
No, this is fusiform, sir. This is fusiform.
So what is it? Type?
Fusiform is type 1 choledochal cyst.
Yes.
Sorry, type 2 is most common, sir.
Okay, so this is called the Todani classification,
Todani
right?
classification, yes.
So what you have said is a type 1. Type 2, as Sir said, is saccular.
Yes.
Type 3 is a choledococele. Okay.
Yes, ma'am.
Type 4 is both intra and extra. Type 5 is only in the extra. And type 6 is only in the intra.
Yes, ma'am.
Okay, so this is type 1. So if it is a type 1 Todani classification, then what is your plan of management for this patient?
Ma'am, the management might change depending on the age of the patient, ma'am. If there is, and the symptoms of the patient. If the patient has consistent pain and the patient's age is not a aged patient, then we might need to go for surgery.
Why are you concerned about the age?
Patient needs surgery. No, age is not the criteria.
Exactly. Why are you concerned about the age?
Ma'am, actually,
even elderly patient can present with choledochal cyst. The treatment is same.
Okay, ma'am. Actually, because for the risk factor is if it stays for a long period of time, there is chance of malignancy. So that's why I said so, ma'am.
So
No,
it
no.
is
If
considered
the presentation is important, if the patient is present in the adult age
Okay.
with
and you have
symptoms.
choledochal cyst, treatment should be the surgery.
Surgery.
Okay, if it is
So don't
such that it
complicate
is
the
an
situation. You are
yes,
asked the management. So describe the management. It's a type 1 choledochal cyst.
Okay.
The standard of treatment is
surgery.
Surgery.
what
Okay, so
surgery?
what surgery will you do?
It will be the excision of the choledochal cyst with Roux-en-Y hepaticojejunostomy.
Roux-en-Y hepaticojejunostomy. Now let us say that the extent of the choledochal cyst, the extrahepatic extent of the choledochal cyst, does it interfere with your plan of management? Meaning how far the choledochal dilatation is from the hilum, the junction of the two right and left CBD, intrahepatic
Right
ducts.
and right and left. Ma'am, depending on that, the intraoperative management might change.
What? That is what I'm asking.
Ma'am, because if it is right up to the hilum, sorry, the junction of the right and left hepatic duct, ma'am, then there many surgeons do separately connect it to the
So
jejunum
exactly
or
the point. If
yes, ma'am.
there is a length of CHD which is uninvolved, then
ma'am.
an excision and a Roux-en-Y hepaticogenesis, what you said is absolutely. If
Yes,
it is
ma'am.
going right up to the junction of the right and left hepatic duct, then
Yes, ma'am.
excision and separate anastomosis in the
anastomosis.
right and left has to be done.
Yes.
Okay, fine. I'll state that. I'll just move to the next image. Who's the next candidate? Sagir or Jishan?
Jishan.
Jishan. Jishan, please unmute yourself. Jishan. Jishan, are you there? I think he logged out.
Jishan, you unmute.
He seems to have logged out. Shoham, can you come back, please? Shoham?
Yes, ma'am.
Yeah, you take this. No use
Ma'am,
wasting time. Yeah.
ma'am,
Describe this, please.
this is an axial section of the NCCT brain showing chronic subdural hemorrhage.
No, no,
How
describe
do
the
you know
picture.
chronic? Describe first.
Okay, ma'am.
You
Ma'am,
said
showing.
chronic. I mean, the moment you say chronic, I'll go into that. So
Okay,
just
ma'am.
describe here.
Okay. Ma'am, showing a crescent-shaped radio, not radiodense opacity in the right lobe of the brain with a midline shift with
This is not like
obliteration.
a typical acute subdural, which is radio dense. Is
No,
it?
sir, no, sir. And with
So what are you looking
obliteration
at?
of the right ventricle,
Right ventricle is compressed.
compressed.
Okay,
And
so
what about the midline shift?
yeah,
Yes,
he
ma'am.
did comment
Yes, sir.
on
I
that.
mentioned, sir, there is a midline shift.
See, when you describe a CT brain, there are 5, 6 things that we want to hear. Okay.
Okay.
So first of all, is there any soft tissue shadow, meaning any scalp hematoma or not?
Yes,
Okay.
ma'am.
So here there seems to be some fluid
Soft
in the
tissue.
scalp. Okay. So there seems
Yes.
to be some collection in the scalp. Number 2, look at the bony contiguity. Is there any fracture or not? So in
No.
this cut, no evidence of bony fracture. In this cut. Okay. Number 3, is there any evidence of extradural hematoma? Yes or no?
No, ma'am.
No, fine.
No.
Number 4, is there any evidence of a subdural hematoma? Yes or no?
Yes, ma'am.
There is a
Yes.
subdural collection.
Yes, ma'am.
Number 5, are the sulci and gyri intact or effaced?
Ma'am, effaced, ma'am.
Effaced. Number 6, ventricles evident, not evident?
Ma'am, the right ventricle is obliterated, ma'am.
Obliterated. Number 7, midline shift or not?
Yes, ma'am.
So you see, so many points have to be said. So don't give
Yes,
a one-word thing. When you say describe, you will go from outside inward and describe all these points. So
okay.
in your case, what is your diagnosis from this cut?
Ma'am, this is a case of subdural hemorrhage with a midline shift
Okay,
and
subdural
a
hemorrhage with
scalp
the
hematoma
right.
on
Now, what
the
is
right
your
parietal
goal?
area.
Right. What is your goal of management? What is
Um,
it that you need to do?
Ma'am, we need to decompress this to avoid the midline shift and
So to correct the
uh,
midline shift. So
midline
your
shift.
neurosurgeon is going to do the decompressive craniotomy. What
Yes,
is your role till then? You are the general surgery resident.
ma'am, we need to maintain the intracranial pressure
How will
and
you maintain intracranial pressure?
ma'am, in a case of subdural hemorrhage, we will use
Don't use
and
mannitol. This will
no,
further
no,
aggravate the
no,
hematoma.
we
See,
can't use that.
see, your
Uh,
answer is going to be only 2 words.
yes,
My goal of management is to avoid hypoxia and avoid hypotension.
yes,
That's it, right?
okay.
Because the primary brain damage has already occurred. Your
Okay.
aim is to avoid secondary brain injury by avoiding hypoxia and hypotension. Okay.
Okay.
Now, if you are asked, then you go into say, how do you avoid hypoxia? How do you avoid hypotension? That's the second question. Goal of management is prevent secondary brain injury by avoiding hypoxia and hypotension. Okay. Now, sir had already taken you into what medications you will use or not use. What medications do you think you are going to use for this patient?
Ma'am, ma'am, I am not going in order, but we will use not epileptic. Uh, we will
Anti-seizure drugs. Yes, you will.
anti-seizure drugs,
Yes.
anti-seizure drugs.
Yes.
We will use some
Sir was asking about mannitol. Will
mannitol
you use mannitol or not use mannitol?
Ma'am, in epidural and subdural hemorrhage, we uh, generally avoid mannitol.
Now, in both epidural and subdural?
No. In subdural, we can use. In epidural, we will avoid.
Epidural, you will not use. Subdural, you may
We can
use.
use.
Right.
We can
But
use,
in
yes.
a subdural hematoma, before using mannitol, what is the one thing that you have to be very sure about?
Um,
The patient should not be in shock.
okay. Yes,
If the patient is
definitely.
in shock and you give
We can't
mannitol, the
use.
shock will get aggravated.
Yes.
Okay. So yes, extradural, definitely you will not give. Subdural, you may give, but you have to rule out and be sure that the patient is not in shock. Anti-seizure drugs may be given. What will be the position of the patient while you're waiting to shift him to surgery? You're going to give a slight head up
Head up.
because you want a good
Reduce
venous
the
return.
ICP.
Yes, and you reduce the ICP. Okay, fine. There's one last image that I have. Who's going to take it? There's one.
Yes, Sagir can take. Sagir.
Sagir, is your audio sorted? Sagir?
Yeah.
He's not responding. Shoham, continue, please. This is your image.
Hello, ma'am.
Oh, Sagir is there. Okay, Sagir, please respond. Please take this case. So there is this lady who's come with she's a 43-year-old lady with a lump in the lump in the breast, and you have asked her to get a mammo. So describe the mammo cuts, please.
Uh, uh, this is a mammograph image in lateral view and
What view?
Mammography has different views, not
What are the
straight
two
lateral only.
views? What are the views? So you can see there are two images.
mediolateral MLO view and
That is a lower one, mediolateral oblique. MLO is mediolateral oblique.
mediolateral oblique
And what is the upper view? The image on top?
You can see the upper and lower. So it's a craniocaudal.
Craniocaudal view.
So CC is what? You see, it's written CC. CC is craniocaudal, and the
Yes,
other one
ma'am.
is mediolateral oblique. Okay. What do you see in this image?
There is a discrete calcification present, and
Calcification, will you directly jump into saying calcification? First, describe what you're seeing. What are you seeing? Which one are you talking about, the right or the left?
right, ma'am.
Right. Where do you see a calcification in the right? Where do you see a calcification in the right? See, these are the normal densities of the breast. This is not calcification. In
Yes,
an elderly women, we usually do a mammography, the breast is less dense. If you had a younger woman, this whole thing would look white. That is why we
yes,
don't do mammography in a younger woman. So this is the
yes, ma'am.
normal density. Now look at the left side. Can you see anything different? Can you
Yes,
appreciate
ma'am.
this? Can you
And
appreciate this?
small lump in left breast in the lower side,
Lower side. How do you know this is the lower side?
because
If you go, if
axilla
you
is
go by
seen in
the
the
MLO, it is very easy that this is the upper quadrant, this is the lower quadrant, right?
yes, ma'am.
This is upper, this is lower. But in a
Yes, ma'am.
craniocaudal, how do you know which is upper, which is lower? So the easy thing to remember is, by convention, the upper part of the image is always the outer quadrant. So we say upper inner, upper outer, right? So from
Yes,
the
ma'am.
MLO, you will know the upper and the lower quadrant. And from the CC, whatever is above the top part of the picture, that is the upper quadrant, and whatever is below is the inner quadrant.
Yes,
Okay?
ma'am.
So upper and outer and inner, upper and lower. Now coming back to this. So this is what? Inner,
This is small
inner. Is it,
lump
no. Is it outer or inner? Is it outer
inner
or inner? It's inner, number one.
inner.
Now look at this. Now tell me, is it upper or lower?
It's lower, ma'am.
Lower. So it is a lower inner
Lower
quadrant.
inner quadrant.
Got it? So that is
Yes,
why we have two views. It is a
yes,
lower inner quadrant lesion. Is it well circumscribed or not?
yes, ma'am. It is
It is
well
well circumscribed.
circumscribed.
Is the density smooth or not?
Smooth density.
So now tell me, is it a benign mass? Do you think it's a benign mass or a malignant mass?
It benign mass, ma'am.
It is probably a benign mass.
Probably benign mass.
Okay. So now what are the features of a malignant mass?
Speculated margin.
Okay, number one. So it will not be homogeneous like in this.
Not
It will be
homogeneous.
heterogeneous. It will be
Heterogeneous.
speculated. What else?
Maybe discrete calcification,
Okay,
microcalcification, maybe.
one minute. If you say calcification, are all calcifications malignant?
No, ma'am.
No. So which calcifications are more probably malignant?
Small microcalcification.
Macrocalcifications or popcorn calcifications, they are evidence of benign disease.
Benign.
Yes. Or if you have scattered calcifications across the breast, they may be for DCIS, ductal carcinoma in situ.
Yes, ma'am.
Right? So these are
Yes.
the classical features of a malignant lesion. Also, you will look at the axilla. If you see any evidence of nodes, what are the features in a node image which will tell you that it is a metastatic node or a benign node?
Don't know.
Right? Oh, sorry.
What size is significant?
Sorry, it got unshared, but I'll continue from here.
Size of a malignant node is larger.
So we usually say subcentimetric or more than 1 centimeter. Is the
Yes,
size the only point, or is there something else that we also look at? Classically, you will see the report, they describe that the hilum is maintained or not maintained. If the hilum is not maintained, then it is loss of hilum is usually an A of a suspected malignant node, metastatic node.
okay.
Right?
Okay, ma'am.
Okay, now this is the image. What will you do next with this lady? 43-year-old with this mammographic image. What will you do next?
Sir, ma'am, we can do further investigation.
What further investigation? Be very specific.
USG
guided?
bilateral based and then for FNAC.
FNAC 2026. Please don't make that blunder. So it is
lump
triple
in the breast, you
assessment.
do FNSC or you do something else?
No, core cut biopsy.
Exactly. So triple
Image
assessment.
guided biopsy.
So you have done an imaging. You can, if it is a big lump, even without image guidance, you can do a core. But the best thing is to do a USG guided core needle biopsy.
Biopsy. Yes,
And
ma'am.
then take your treatment forward depending on your biopsy finding.
Okay. Dr. Chatterjee, we'll
Yes.
conclude today.
Okay, sir. Thank you so much. Thank you,
Thank you.
participants.
Thank you.
Thank you,
Nice
ma'am.
pictures.
Thank you,
Okay.
sir.
Thank you, ma'am.
Yeah.
Thank you, ma'am.
Thank you.